Good afternoon, everybody. It is Friday and it is September 1st, Labor Day weekend. You're here at Lunch and Learn. Today we're doing part two, and we were just discussing it, probably going to part three of the sort of the functional neurofeedback treatment planning and looking at all the things that we do. On Wednesday, we spent almost all of the time talking about, the concept of functional neurofeedback and holistic health and get into the physiology in great detail. We're going to start off today with the ISI, but I wanted to show everybody that's here a few slides. This came from Dave Cantor's presentation on toxins, and you can see here in this particular slide, this is the impact of lead poisoning on a QEEG. Looky there. But look at this QEEG and some of the spots that are super high or super low. So that's just, again, looking at lead poisoning, which,
think
go
you
ahead.
need to make clear what those blue things represent, Rob.
Oh, these are probably 1 hertz bins, aren't they?
I don't know.
I'm assuming these are 1 hertz bins. I think that's what he
That's
was
not many
talking about.
hertz. That's
2,
4. That's the first
5,
4, 8. That would be
9, 10,
12.
11, 12, 13, 14, just on slow wave then.
That's at 14.
I'll have to go back and check.
Yeah.
Yeah.
I was
But you
just
can,
curious.
yeah, it's all low, it can lower power. So when we're looking at, for example, the reason for showing this, you're looking at a low power map, it could be certainly sleep related, but it could be also physically health related. And that's why this whole concept of looking at what's the cause versus just saying, oh, you don't sleep well, you get a low power map.
So he has 2 hertz frontal delta, right?
Yeah. Now, yeah, that's there, and I'll
Right
go
frontal
verify that.
delta.
Yep.
Mhm. Okay, makes sense.
Lead, leading cause for compromised attention and learning. Well, these are just some citations, so it's there. Okay, he's got the research to support that. This slide, Fulton County. This is from Georgia, right? Fulton County, is that Atlanta?
Yeah. That's
This is
scary stuff.
this is the normal stuff. These are what they're measuring, and copper seems to be okay. It doesn't seem to be so bad, but look at lead, and that's what the focus is of these slides, is just lead. It's just quite dramatic when you start thinking about just one of those heavy metals. And
That's
then,
really dangerous.
yeah, that's, yeah, very dangerous. And then just look at from symptoms and locations of heavy metal toxicity. Look at this. You can get lead out of milk products, bone meal. He highlighted
Well,
those.
they're
Those were his
drinking the
highlights.
same water we are, right?
Yes, exactly. Yeah, the
And a lot
cows, you're
more of it.
exactly right. They were talking about, atmosphere and so forth, and air. And what one of the things that he and Rusty were saying was, you think, you're living in a city and you have all these, potential pollutants, but when you're in the country, you're safe. No, there's something called weather. There's something called wind, and there's something called atmospheric changes. And you're not any safer out in the country, based on some of the research they were showing us, than you are in a city. I mean, maybe it's less contaminants in the air, but than being that
You
you're
have to be
smelling oil
way
plant.
out.
You have to be way out. And
Rob,
there's
on the slide above,
yeah,
there's a
yep,
category that says, does water meet EPA standard? And on both of those, copper and lead, it says
yeah,
yes, which
yeah,
is also a scary thought. So
exactly
I know
right.
this is an older, but the EPA standard does not to us mean it should go in your body.
Right. It's just they're just saying here's the standards we're meeting, but obviously, as you're pointing out, still some problems. And then look at all these various symptoms. And most of these are, again, physical health symptoms. But we think, oh, well, gee, well, what's causing depression? Is it just asymmetry? Is it just somebody who's got a bad, situation in their lives? So anyhow, I just thought those were interesting slides to start with, just to get people back on page with, we looked at physiology and its impact and why it's important to do more than just, do a map. And Richard, I'm going to give this screen over to you.
I think that thing is really important.
Yeah.
Oh, you want me to? I didn't know I was supposed to have an
Oh, you
ISI.
don't have,
I thought
well,
we were using the ISI on on the
Oh,
case
yeah.
that we were looking at.
Okay, so Judy, do you have that case to pull up, the ISI?
I do. I
Okay,
do. Okay, send it over my way.
all right.
So this fellow came the other day, and part of the reason I brought some of his studies is because he has what his brain shows and what he thinks is going on are so completely different. And so I know we can use this one for you to pick out what you normally are looking at in terms of different criteria, but I brought it because this fellow, who is really, really anxious and quite lots of different MAP symptoms, has an ISI that's, you know, better than a lot of them. So
Well,
I can also get you a different one if you want to go from there. If you can't, if you want to pull out
well,
from this.
is this the guy that we're going to be
Yeah.
summarizing? Yeah,
Yes.
that'll work. Any ISI
Okay.
will work.
Okay.
But you say he's very anxious.
Yes. If I flip here for a moment, just so that's what we'll
Oh,
be
yeah,
looking at in a bit to the dashboard.
that's really significant. He's
Right.
really anxious, but he's not reporting it, right?
Yes, exactly.
Yes, that happens every once in a while. That makes this even more valuable, is you
Right.
expect there to be a congruence, you know. But as hard as you try with different instruments to correlate them, they measure the same thing, and they're accurate, but each individual varies highly in how they express their symptomology. Again, I made that uh, point really clear last Wednesday. I always try to make that point, is the individual complexity of human beings is such that it's almost impossible to categorize them into groups, which is why there was a failure of the DSM and why all efforts to measure them with agricultural science, a la control group designs and statistics, fails. And that's why sociology and psychology use much more complex statistics and designs than control group designs. They have to, because of the complexity of human beings. And if you've got a PhD in any of those fields, you're acutely aware of that, because they're always struggling for empirical evidence. And they always feel behind the ball because they can't produce the same quality of empirical evidence as in physics and chemistry. Well, of course you can't. People are more complicated than atoms, and they're at a different scale in the universe. And so there will often be people who it doesn't match what they report and what they feel and what their physiology shows. Physiology is a lot more grounded in the physics, whereas when you're taking a measurement through a test like this, you're going to get, you know, ordinal or semi-interval information. It's not going to be the same quality of interval information as the EEG. They just can't. It's too complex. I mean, any one of these dimensions is way more complex than the EEG. So sometimes people will not clearly represent themselves for a lot of different reasons. And that's not a time to assume the instrument is monitoring them incorrectly. The instrument doesn't change. It's been tested statistically. It is very accurate, but it's dependent on report, which is one of the reasons we say you really shouldn't use it on people younger than 18. Well, you may feel like you're getting it, and there may be 16-year-olds who do a pretty good job, but they've extensively tested in psychology for 70 years. They have a whole science about measurement of human feelings and emotions and expressions. And what they find is that self-report is highly unreliable, until you're over 18. And even then, it's not always great. You know, the more mature the individual, and you know, the more development you have in the brain, the more the self-report becomes reliable. You know, an 18-year-old is not going to be as self-aware and control their have the inhibitory control of a 25-year-old. It's just not going to happen. And you become more aware. And there's a reason the insurance companies don't like to give cars to people under 25, and they charge extra for it. So here's a person, regardless of his age, who's not accurately reporting. This thing is giving him an opportunity, but he just doesn't self-report clearly. And you should be able to tell. Another way you can tell is to look at the difference between the CEC and the ISI. The CEC asks them outright what they're feeling, but this doesn't. It's harder to deceive. So the more that they answer this honestly and doesn't agree with the obvious observation and the brain map, the more it disagrees with the map, the more you know that they're unaware or they're not doing it on purpose. Well, most people don't do it on purpose. You know, maybe your 2 or 3% personality disorders do it on purpose, but you know, most of the time they're unaware, and that's classic. Most people aren't that aware of their emotional and physical status, and that's how we all get into so much trouble. And
I
that's
just
why
want to
stress is the
interject
silent
one
killer.
thing.
Yeah,
Just one thing I want to interject on this.
sure.
I picked this one purposefully because it's a little more of a sophisticated conversation, in that I'm going to say 90% of the time for me, the ISI and the dashboard, I mean, it matches. When they show a
Yeah,
lot of depression, anxiety, so does the ISI. It is, so to speak, hard to fool. And so by the time I'm meeting with them and have examined the ISI, I have a feel for them. So when I
yeah, that's a
saw
good point.
this, and then the map, I thought, this fellow has really like fooled himself so well that he wasn't trying to not take this accurately. He is trying to he took this very seriously. And yet, you know, it's so different from everything that we see. And my conversation with him, I just brought that out. But so it is not our norm in the ISI. And if you would rather look at one that matches, I can do that as well.
No, I think this is good because this is the worst case scenario they're going to run into.
Okay.
I mean, why not?
Yeah.
The other thing's pretty obvious, like you said. It's a really good edification. What you said, they use what, and everybody can pretty quickly get if they match. But what happens if they don't? Then you're filled with doubt, confusion, if you don't know the point we're making and what you just said. It's really valuable. The exceptions are the things that trip you up. And in that, and you can see in a lot of in the other areas, he doesn't match the map, so he's not aware of his anxiety, so he's not going to report on his being inhibited as much. He's repressing a lot of his experience. Um, he has to be somebody who's trying to cope so hard that he's just blocked information out, and plenty of people do that. And the key things, you know, I look at inhibited and impulsivity and passivity. Impulsivity generally is high when anxiety is high. So that's a little high. You know, you can tell there's some anxiety there. He's somewhat inhibited. You know, it's more than the peak performers. So he's got telltales, even though he's suppressing it, it's there. He's high on passive. If you understand passivity, it's a defense mechanism. It's it's an attempt to go along with someone else in order to avoid conflict and hide your feelings. So to do that, you have to be anxious. You have to experience trauma sometime, and you have to put up a defense. Passivity is a defense, and it's a form of coping. So there's more anxiety than being reported here. He's less assertive, and that's not that significant. He's not that flexible. That's not that significant. Perfectionism is something to look at. Perfectionism correlates very high with anxiety. You can take 5,000, 10,000 people from the database and look at the correlation between those two, and it's extremely high. So I'm not plucking this out of observation. I'm plucking it out of statistics, not clinical observation. So the statistical fact is that that highly correlates with anxiety. And if that's high, anxiety is higher than it looks. Cooperative, that's a good score. That's nice. It's interesting that he sees himself as cooperative. He likes to come across that way. Competitive, again, if that's a little bit high when the perfectionism is high, in 90% of cases, there's going to be some degree of depression. He's not showing it. So that's there too. He's a little bit depressed, but he's hiding that in his answer. Well, he's not hiding it on purpose, but he's misreporting. Dependence is very high. When you get dependence and perfectionism high, that's common in addiction. It's common in codependence, and addiction is very prevalent in our society, more than people realize, because they only report on street drug addiction, and now they start to report on pharmaceutical addiction, because in the last 30 years it's gotten really bad. But still, they only cover drugs. There are many other things to be addicted to: gambling, sex, food, and the list goes on, and it gets bizarre. So it's really a common response to stress. And we are a stressed nation. So dependence and passivity are high. This is a person from an addictive background. Addiction tends to generate addiction. It's a transgenerational behavior, and it's wrapped up trauma, violence, and sexual abuse. I mean, they all roll together.
Both parents were addicted, and you didn't even know that.
No,
Both of his parents. But the information tells you that.
Yeah, well, it's built up by scientific principles, 100 years old, carefully developed by psychologists on putting statistically an accurate instrument together. And so it's not empirical in the sense of the EEG, but it's semi-empirical. It's valid. It's a way of turning ordinal into interval information that's more accurate. So I like to call it approximate interval. And it's built on solid theory, 50 years of theory. I mean, this is a really concrete, well-designed instrument. A lot goes into it. So there's a lot going on, and there's addictive in the background. There's a lot of anxiety. He's codependent. He's conflict avoidant. These are all things that, if you read about this instrument and try to understand it, it will help you gain insight into them. And sometimes when they have like a head trauma and they have strange behavior, you can tell how much of the behavior is from head trauma and how much is it from the socialization process, because that's what we're really measuring here, is the socialization process, the lack of support, proper support. It's actually a proxy measure of toxic stress at a very fine level. And you get the interactive. Now that's interesting. He really likes to interact with people, but he's really afraid. to interact with people. So he's got a core issue, and it's different from a personality disorder, because a personality disorder is the interaction will be down. They don't like to interact with people, and boom, they're really highly avoidant. And that really starts to get into extremes of social behavior and personal behavior, manipulative and out of control behavior. So there you kind of get an insight into what's going on with him. He's suppressing a tremendous amount of information. If you do alpha theta with somebody with this much conflict between their EEG is telling you and their history is telling you and their and this is telling you, you're going to have somebody who's going to really react strongly to the alpha theta or not at all. They're going to be really hard to get a crossover, or they're going to be really reactive because a lot's going to come up. So that's what I think those are the key points about the ISI. Any questions? Or and of course this is all in the, if you go down into the interpretation, it's individually interpreted. And I even have even the new people come on board. They look, oh, I like this. This is accurate. Everybody tells me that, but it should be. I mean, the darn thing took like 15 or 20 years to build.
And
And
it's good
that
information
explains.
too. You know, I mean, people can go there. It tells you things you can do to help correct things and all that. So it's a lot of great, readily accessible information.
Yeah, I'm not a trained medical practitioner, but I'm a highly trained in measurement and observation of human behavior at the sociological and the psychological level. And I put everything I learned into this, and it can be a valuable tool if you spend the time.
It was so interesting to have this and then see the map. And I had to shake my head for a little bit, like, what the heck's going on here? I'm sorry, there's outside noise. It's stopping in a moment. But I had to like shake my head and think, okay, where do I go with this? Because he has such a disconnect internally, you know, so it also, you know, the idea of what we are doing in these couple of sessions is about developing, you know, a healthy treatment plan, and so this ISI made it even more complex because I knew my conversation had to incorporate what this said about him, you know?
Yeah. Mm-hmm. Mm-hmm. But there was some disconsternation at the disagreement, wasn't there? It always trips you up. You say, whoa, wait a second. How am I going to
I
handle this?
I've been a therapist for a lot of years. Honestly, if I wasn't a therapist, I would have been a lot more probably. I was thinking about this last night. I'd have been a lot more concrete and just pointed this out and then pointed out the difference in the map. And because I'm a therapist a long time, it made me think a lot about how I wanted to approach the fellow and have this conversation, and bring him with me into this place. And you could
Yeah.
just see the changes on his face as we had that conversation.
Oh, presentation is everything. It's critical. Everybody can only handle so much information, and you have to decide what information do I have that I can give this person, which is going to help them the most and not overwhelm them.
Yeah.
And they can only take it in small bites.
Right. And I made him record our conversation because I really felt that. Yeah,
Well,
sometimes I
that's
do that because I talk too much. And I tell them, I know you might want to tell your spouse this, or you might want to think about it later, but you're not going to be able to remember because I'm going through, because I take them through the map and the studies,
yeah,
and it's a lot of talking
it
after I
is.
get some history from them. So, and I don't mind if they record me, and they can listen to it again because, I know this fellow. Well, when I saw this, and we'll come back to this, I know, but um, verbal and visual, he's tracking at 7. So I knew I was looking at somebody who it maybe wasn't coming in and gonna, so he needed to be able to listen to this again, you know?
Mm-hmm. It's
So I don't
interesting
mind.
that he's tracking at 7 isn't.
Mm-hmm.
Information isn't being accurately interpreted. So his interpretation, that may be a key point in where his um, misunderstanding or misevaluation of himself is. It may be in that error in his interpretation of what others are saying to him.
And not to mention the fact that when it comes to doing treatment planning, he's got to be able to understand and work with what you're telling him and putting together a
Yes.
plan to get better. And if he's not grasping all that, then that makes it more challenging.
Yeah,
This is
that's why
somebody that, excuse me, go ahead.
I
Go ahead,
say
Richard.
in the symptom tracker, that's why we don't want to use all the symptoms at once, or overwhelm them or let them,
Mm-hmm.
they try to pick too many out, they get, I got to get perfect, so I'm going to take them all. We have to
Yeah.
rein them in. Go
I
ahead,
limit
Judy.
them to 12 to 15. I say, let's pick 12 to 15 and pick them all, then go back and take out your duplicates, pick the ones you think are most relevant, and let's try to limit it to 12 to 15. I don't know what other people do, but I think
You're generous.
oh,
I go maximum 10
Yeah,
for the same reason.
yeah.
I mean, it's just so much. I remember if you didn't give, I remember not telling somebody a lit the first times I started using the symptom tracker, and this woman came in with a checklist of 60 items.
yeah,
I went, we need to narrow this down a little bit because it would take me an hour just to go over her progress tracker.
I
Well,
had
there's not
somebody
going to
pick
be any
7
tracking.
anxiety, worry, anxiety, and 7 different words they picked. And so I said, let's pick the best one here. What do you think? And we got down to 2 of those 7,
Yeah,
you know?
there you go. There's a technique. Okay.
Other questions on the ISI? Anybody? Comments?
Or how other people use it.
All
Yeah,
right.
I'd like to just remind everybody that in the help section is a documentation for it with full technical explanation, where the concepts come from, what they mean, and the references for them. And for those few individuals, rare individuals who are really interested in the statistics, that's there too.
Where would they, on this screen, what would they hit for that?
Help.
I'm not,
If
oh,
yeah,
there it is, up there.
yeah, that's why
That
I don't.
one.
I think a lot of people don't hit the help section because it's up there in the corner.
Yeah.
You've got
Do you want me to
share.
hit
Well,
it?
I'm not
You
going to
want me to
share
hit it
mine.
to show? Shall I hit it to show the categories or just
Yeah, you
let
can do it. Yeah, you can do it.
okay.
There they are. It says normative distribution of the database. That's not been updated, but ISI, validity and analysis, that tells you the CEC, tells you how we put it together, where the concepts came from, what instruments it was cross-correlated with, what the statistical cutoff points were, and what statistics we use. And so there's no mystery. There shouldn't be any doubt about the validity and reliability. Those numbers are in there too. I think that's been replaced by the YouTube channel videos. I have a standing request to replace those, but we'll get there.
So there's the ISI, the theoretic background.
Yeah.
Wow.
Solid. That's a review for the whole thing.
Very cool. I've
Yeah.
never pressed the help button, but I will do that.
Well,
Now
there
you
you
can
go.
get lost in it, right?
Yeah.
Yeah. It tells you where it came from, the theory, the people, the authors that were drawn from, the research.
Let's see the bottom, how many sites you put. Oh my goodness, look how long this is.
Yeah,
And
well,
I'm
it's
not even,
a big
it's a great,
instrument.
yeah. Oh, wow. Wow. When you said 15 years to do it,
She's got
Now we
you
3,000.
weren't kidding.
Got an N of 3,000. That's a pretty good number in that
Yeah.
theory.
Yeah. Slightly over the typical 30.
Yeah. It's not a lightweight instrument.
No. But this is important for everyone to understand too, that, when you have questions about it or to understand it, or when you get those occasional clients and patients in that are academics and researchers and they want to know what everything is all about and why it's so good, this is one of the places you can turn, is that help section. To educate yourself better, to explain it to a client that wants to
Wow.
know.
And they weren't all NIH scientists. Snark, snark.
Wow.
So you can get the whole picture.
All right.
Okay.
Let's go on to the C. We're not going to get to everything today again, but we'll go on to the CEC. Everybody ready for that?
So for me to pull up the CEC on this person, you need to take the screen back for a minute so I don't expose other names of clients up, because I have to go into New Mind Maps to pull him up again.
Aaron
So-
doing that? Is he there, or should I do that?
Yep, I got it. I'll give it back to
Just
Rob
for a
for a
second.
second.
Thanks.
All right.
You don't have to accept if you don't want, Rob.
Oh no, I just, you get a picture of the boat.
It's a
I'm
nice
good.
look
Right
at.
now,
Actually,
all this is underwater, folks. We had high tide. The hurricane is gone. It is blue skies, and this walkway to this boat, this ramp is up here. The water is up to this dock, and you can't walk down the sidewalk. And the
wow.
parking lot's flooded this morning.
Actually, it didn't take. I have it. I'll take the screen back for the CEC.
Perfect.
Okay, that. So now this is also a fellow that, his CEC matches, his view of himself is different than what the map shows, as we've discovered through the ISI. So there wasn't much going on here, because I was really here, honestly, when so much of this was going on, that I thought, okay, well, the CEC in the psychogenic, there was a lot of therapy issues that were coming through for
Yeah.
him. So
And that would be the case of somebody who's underreporting. You would
mhm.
expect that.
So it was
to-
really kind of a nothing, mild CEC for me to utilize. So if others want to speak to more about what I use, the CEC in association with the dashboard a lot more, unless there's
that's
a lot of
reasonable.
red coming out,
Yeah.
around intention, and like when it's like this, then it's more of a, whoa, look at how you're coming out compared to where those black marks are around,
Yeah.
but otherwise I use it with the dashboard. So I'm not sure if others use it more extensively.
I use it with the dashboard too, but once somebody has indicated something and it comes up yellow or red, if the QEEG comes up yellow or red, I don't see that as a strength of correlation. If they're yellow and the map is yellow, it's an agreement. If they're yellow and the map is red, it's an agreement. I don't see them as underreporting, although they might be. It's just that's just a probability. So once you got a match, you got a match. But this guy apparently, he has no threes, and we
Right.
know based on his ISI and some other information you've given us that he's probably underreporting here as well. But he reports enough for us to see that the CEC lights up a lot of those columns in the dashboard, which means, well, he's probably not sleeping so well, among other things.
It's also really, really interesting because his presenting was about not being able to focus and pay attention. And so he came with that as I really want to finally get a handle on this, and then doesn't actually doesn't see it as a 3 on a 1, 2, 3 scale
Yeah,
around
yeah.
attention. It's so, the therapist in me gets like, oh, I get so curious here. Look at this, and
Yeah.
that's what I guess the process of getting these studies in advance. Like, I don't let them do that the morning of. I want the studies before. If they don't have the studies, I won't interpret the map, because I usually will do it in one sitting. We'll go get some. I have a little bit of history. I get more history. We go through the map, and I create a plan. They get a training while I create the plan, then we review the plan, kind of thing, just to get an idea, so they can leave. They can either make appointments or they can leave with this info, so that they make an educated info, and they know going in that this is going to be a 2-hour appointment, probably at least, and so they're expecting, and just to tell you my process around coming up. Other people stage it out. They might do the map and then come back another day for what they call report of findings. But I like to, it's a combination of me as the therapist, the clinician, and the salesperson. Because in therapy, they taught me a long time ago, the purpose of the first session is to have a second. That was one of the guiding principles that I once learned.
Pretty
Because
good one.
if they don't come back, you can't help them.
Yeah,
So
that's
it's,
important.
so it's about really how to put it together so that what I see and how I see it and they see it, that we have enough of an overlap. Yeah, right. So all of this leads me to that. All of this leads me there. So just to talk, since we are talking about treatment planning, other people may do it differently. And honestly, I'd love to hear how you go about doing it, because this is what works for me. I came into neurofeedback with 20 years as a psychotherapist, and I've had 10 years of neurofeedback, and so I hear and look at people through that lens initially, the therapist, and now how their brain is working, kind of. So all of that is clicking around the room. Like if I had little bubbles, I'd have little teeny hypothesis in the air, as I'm talking to people. That's kind of how it feels like to me.
Well, I
I
use a
wonder.
similar process to you, Judy, because I too was sort of like chief cook and bottle washer. I don't have a staff, I don't have a technician, I don't have anybody but me in the practice when I was running it. So I did the same thing where I said, when you come in for your map, plan on having a couple of hours with me, to have time for the map, get them cleaned up and review the results then, provided they've done all that. If somebody came in and said to me, I can't, I need a map done as quickly as possible, I'm going away, and they didn't have time to get all the ISI or the CEC or, performance testing done if I wanted it done, I would still go over the map with them that day, but I would say this is all preliminary until you fill all this out. So I'm just giving you a kind of an overview of the findings. Just, you've got a little bit of, it looks like anxiety or whatever, until we can really get in there and see what they're self-reporting. But the counter to that, of course, would be if I were a clinician that had technicians and I'm the person who's going to sit down with that map and review it, the day that person comes in, if I don't have that on my schedule, then of course they're going to have to come back, for set up an appointment with me to go over the map and the tests and all the findings. So I think there's how people do it is gonna be more based on their practice and how they run it versus, a particular style.
See, and I
Yeah,
have technicians, so somebody else is doing the map. I have myself and one other person who usually will field a phone call and get the first appointment, on the phone prepped. And but if over time here, I evolve the policy of if they don't do their pre-studies, I'm not going to do the evaluation. I'm not. And you all convinced me of that I was incomplete. Now look at this guy in particular. What I see on the map and how and who he is are different, very, very different. And if I hadn't had these studies, I wouldn't have been prepared for that. And then I would have had to scramble in talking to him as it became evident. So that's my policy.
it speeds up this discovery process a little bit.
Mhm.
Definitely, definitely. And we, at our clinics, and I managed several clinics across the country, but I got tired of that. And then I did two in the same city, and I got tired of two because it was like three. Geometrically, the problem. So we pared it down to one, and I had a really good office manager and technicians, and we just evolved the policy just to make it simple that they come in, they do the map, goodbye, come back for the results, and gave them time to go home and do all the assessments. And we tell them do the assessments unless they looked incapable, and we would have them come in separately and help them do them in the office. And we did that
Wow.
sometimes. But they had to complete all the assessments before they could come in and get their map. And they paid for it when it was done, when the map was first done. That way, they were under the gun to fill it out because they would lose their money if they didn't fill out the assessments. And we almost never ever had a problem. They always got them filled out in a timely fashion. Now, granted, we're in a special population. It was a highly professional area of the city, and so these were all extremely educated professionals, and they knew how to get things done. I mean, they had high-end jobs themselves. They knew what it meant, what responsibilities they had. So that made it easier for us. And we didn't get that response on the working class side of town, where we also had a clinic. So to be fair, it would be a lot harder to do it that way. So I think you have to adjust your strategy based upon your demographic, and you have to be aware of your demographic. You have to be a lot more patient with lower socioeconomic people. Their burden is so high, they are so stressed, and they are so disadvantaged. I mean, everything, they're always behind the eight ball, and they feel like they can never get a break, most of them, really, when you get to know them. So it's harder for them to get done what should be done if there's a lot of complicated stuff to be done. Or that was my perception.
I guess I have a working class, middle class, educated population. I also, in my office, put a big sink in the bathroom and provide them with shampoo, conditioner, and a hair blower,
Yes, that's a
towel,
good idea.
so they can, after the map, clean up. Because I know if I was talking to them with all the gel in their hair, that wouldn't work. So we did that. We put in, it was hard to find the right size, but a flexible hose for the faucet, and then they wash it out.
That's a good idea. And when we did the map review, we always had paper and pencil on the table for them to take notes if they want.
Right.
And we always told them they could record it on their phone if they wanted. So like
I
you
offer
said,
that 90% of the time. I offer up, like if they're both sitting there, for example, if it's a husband and wife about the child and they're both in the room, I may not suggest to record it, but if I think there's somebody missing, I will say, first off, can your whatever spouse, partner, whoever, is there anybody else you want to have hear this? And I'm willing to FaceTime them in or just call. And if they're working, they can just mute their end and listen. Or I say you could record it. And I don't wait for them to load a recording program. If they don't have one, we go to their camera, which has a video, and they just push video, and that'll get the audio. Even if, you know, if they set the phone down, it won't get any video, but it'll get the audio. So we don't take time to figure out how to do that.
Yep, there's a lot of working parts to doing this, aren't there?
Mm-hmm.
Yeah, and the way we reviewed the maps evolved too. I mean, from just looking at the maps together on a table to eventually having a big screen on the wall and having them sit there and going through it that way. And then we had to decide what map parts of the map and what parts of the assessment we showed them in what sequence, and that changed from time to time. And even from client to client, depending on what their capacity to understand, often determined, you know, well, we won't show them quite so much because they're not at an education level, or they don't, you know, not likely to understand it. There's such a different field. We're just going to show them the simplest part, and so we, like you said, had to pick and choose what to present physically to them, besides informationally, what we thought they could bear.
Was going through a time where I would just say, so this is what I see on your map, and not show that. People
Yeah.
want to see the data. They want to look at it. That's what I have learned. When people are they're almost mad at me. They're certainly unsatisfied when I don't show them the map. And I think maybe we should do a session on how we show a QEEG to the client and what we
Yeah,
do.
it's been a
And maybe
long
we
time
should,
since we've done that.
yeah,
I agree. Mm-hmm.
you know, but that's when I don't show them the map, they're mad
Oh,
at me.
it's like taking the candy away. It's
You
like
know, and I go through
promising.
a whole thing, I explain everything, and then they say, well, can I see it? And then I have to go back because I have to say, and this is what, when I was saying this, it's over here. So I'll always show it to them. The slide bars made a big difference because I don't have to explain so in such detail, because
Oh,
the slide bars, they
they
just,
were
you know,
a real
that was
relief.
a
For
godsend.
me, they were a relief, a godsend. They were for me too, because that made it way over everybody's head, and they would get lost in that stuff. And it was just, finally, that's why I pushed for them. They're just such a relief, and they made so much more sense for presentation.
So are other people thinking things that they're just not pushing their button to talk about? Because our last few minutes, I'd love to hear from others, parts of this that they agree with or do differently. I think this is a nice learning opportunity. At least for me, it will be. I'm interested.
Yes, I have a question. And it's so interesting to put all of these three physiology, CC, ISI together. My question is about how, sometimes you see their ISI and the physiology are really bad. And you look at their map dashboard and it says psychogenic is normal. That I'm a little bit confused.
What do you mean by normal? The green lights?
Yeah.
Yes, that's what defines them as psychogenic, and that confuses everybody. And that confused me when I first confronted it. It's something that came out of the data, which we had to reconcile ourselves with. And what it is when they have symptoms but they don't show up in the map, it turns out those symptoms are an artifact of anxiety or depression, all of the physiology symptoms that you see in the physiology checklist are also known symptoms of anxiety. It's a fact. It's been known since, well, at least since I was in school. And if the map isn't showing that, I mean, isn't showing those symptoms, then they've got to be due to the anxiety. And anxiety doesn't distort a map that much. As a matter of fact, you can have a map that looks pretty normal, except there might be a little bit of low theta in the back, and the asymmetry will be beta all to one side, but you won't see any other, it'll look normal, almost normal. It can be very deceiving magnitude or dominant frequency. You have to look at the asymmetry to know if there's any anxiety there. So you can have a fairly normal magnitude map and dominant frequency map, and it would all look absolutely normal, but you'd have all these things that they said they were feeling was wrong. And say, well, why are you feeling so bad when the map looks so good? And then you look and you see the asymmetry, and you see that it's anxiety. It's the anxiety creating all the symptoms. It's not a structural problem that the brain has evolved into. It's a functional problem that is a result of anxiety. And it's just really, turns out it's quite simple, but it's hard getting there. Does that make sense to you?
Not really.
Yeah.
It's a
Oh, well,
hard
that
one.
would,
It's a hard
well,
concept to
well,
get.
well, we should probably have lunch and learn on that,
And what will
because
we call that topic? I'll make a note.
Differentiating dashboard and psychogenic.
differentiating anxiety from organic problems.
But put something with the psychogenic section of so people will know, because until
Okay.
I lodged it in my head that these are the therapy issues. This tells me
Yeah,
more about the therapy issues
it
in the
does.
local psychogenic, but understanding how it doesn't show in the EEG particularly, more I can hear about that, I think the better.
Yeah, we didn't know till MRIs that you could get the same symptoms out of an organic problem as out of a psychological problem. And some they can they look differently in the brain, but they look often similar in the symptom. And that didn't really occur until the 1990s, early 2000s. And hasn't even really been understood at the lower academic level. I mean, they discuss it all the time at the imaging level, but they're still struggling with it. It's a new concept to most people.
So if I understand you correctly, this person on this particular map needs to see a psychologist. So another word of saying is a local psychogenic is organic issues stemming from beta reversal and alpha reversal. The degree of organic level of reversal. Is that what you are saying?
By organic, what I'm saying, the reversal is not an organic issue, it's a functional issue. I mean, it's a fine distinction to be made, but putting that aside, it's mostly a functional issue. You can reverse the anxiety or depression, and those symptoms will disappear. You can't always, and you can't, as often it's very difficult to impact an organic issue. Somebody with a head injury who has all of these symptoms is going to be a lot harder to change because it's an organic structural problem with the brain. Whereas when these symptoms appear in a person who's been highly stressed and they're anxious or depressed, you're going to often dissipate them just by working through the anxiety and depression. You can talk therapy somebody out of anxiety and depression. You can't talk therapy somebody out of a stroke or a TBI. It really is what it comes down to. And you can make that distinction with the map, and we've done that. And again, we can go over it again and again. It's preconception that prevents you from understanding. It's the way you were taught. It was difficult for everybody to wrap their head around this idea because we had a century of being told differently, and we've learned it's not so simple.
Could we make a simplistic statement, and then I know we have to wind up? If looking at, okay, so the over-arousal shows up as high, okay, and poor emotional self-awareness is in the psychogenic. Can we make a statement and say, if with the neurofeedback, we move over-arousal much lower, right? That does not necessarily say that he is going to improve his self-awareness, that he will be less restless, he will rationalize less, but these will still be issues that need to be worked on. That's even when the anxiety drops. I'm off
Well,
then. That's not accurate enough for
I think
my.
I think that doesn't make I think there's truth to it, but it doesn't make the distinction clear enough.
All right.
So I can see there's still a problem with this. So we'll make a special presentation
Yes.
for it,
Yeah,
and I'll
I'll
give you example of people who have different maps but the same symptoms, and one's a map of TBI and one's just somebody of anxiety, and then how fast the maps resolve, and then I think it'll make it more clear.
I'll
Okay.
email you and Judy and Veronica, and we'll come up with some dates because I know that some people are gone over the course of the month with time off, and I've got a surgery coming up. So the
We've
four
got
of us
lots of
get
stuff.
together. We got plenty of time. So folks, we will get it on the agenda. We're going to continue this discussion into part 3 for sure, but we're out of time today. So we may pick it up, I think, next Wednesday, since Monday's a holiday.
Well, I'm away next week, so I'll get you this map. So if you want to
No,
continue
we'll wait.
using this map,
We'll postpone it till you're here.
and the following week I'll be there.
Okay.
Okay.
Perfect.
Perfect.
All right. Okay, everybody.
Good
Have a
holiday
safe,
weekend to you all.
have a safe holiday weekend. We'll see you next Wednesday.